venous thromboembolism, VTE, and hormonal contraception. Background. Hormonal contraceptives contain either a combination of estrogen and progestogen or combine hormonal contraceptives or CHC, or progestogen alone or progestogen-only contraceptives. In the UK, the majority of combined hormonal contraceptives contain the synthetic estrogen, the ethinyl estradiol. A combined oral contraceptive or COC product containing mestranol is also available, with 50 micrograms of mestranol roughly equating to 35 micrograms of ethinyl estradiol. More recently, COC or combined oral contraceptive products have been introduced onto the market that contain the naturally occurring human hormone estradiol, either as estradiol valerate or as estradiol hemihydrate. Progestogens are often grouped according to the time they were first marketed as constituents of combined oral contraceptives or COCs and may be referred to by generation. Examples of progestogens according to their classified generation. Generation of progestogen. Examples of progestogen. First generation, norethisternone and norethisternone acetate. Second generation, levonorgestrel. Third generation, desogestrel, gestodine, and norgestimate. Fourth generation, drospirenone, dianogest, and nomegestrol acetate. Risk of venous thromboembolism. The term venous thromboembolism or VTE includes deep vein thrombosis or DVT, pulmonary embolism, and cerebral venous sinus thrombosis. Background incidence of venous thromboembolism in women of reproductive age is in the range of 2 per 10,000 women in 1 year. Non-randomized studies have consistently reported an increased risk of VTE associated with combined hormonal contraceptive use, suggesting that this effect is real. What is the venous thromboembolism risk associated with different combined hormonal contraceptives like pill, patch, and vaginal ring? Combined oral contraception. Combined oral contraceptives containing the third generation progestogens, gestodine, or desogestrel are associated with an increased risk of venous thromboembolism or VTE when compared with those containing the second generation progestogens, levonorgestrel, or norethisternone. The biological mechanism is not fully understood, but different progestogens appear to modify the thrombogenic effects of estrogen to different extents. For example, acquired resistance to activated protein C is more pronounced during the use of COCs containing desogestrel than levonorgestrel. In 2013, The European Medicines Agency, or EMA, initiated a review of the risk of VTE associated with use of combined hormonal contraceptives. This review concluded that there was a good evidence to suggest that the risk of venous thromboembolism associated with different combined oral contraceptives was influenced by progestogen type, with those containing levonorgestrel, norethistérone, or norgestimate having the lowest risk of 5 to 7 per 10,000 women, and those containing drospirenone, desogestrel, or gestodine having the highest risk of 9 to 12 per 10,000 women. The risk of venous thromboembolism with use of combined hormonal contraceptives was therefore reported to range from 5 to 12 per 10,000 women years, compared with 2 per 10,000 non-users. However, the EMA noted that the benefits of CHC use generally outweigh the risk of venous thrombosis, which is low overall and is lower than the VTE risk associated with pregnancy and the postpartum period, 29 per 10,000 women years, and 300 to 400 per 10,000 women years respectively. Despite evidence of more favorable effects on lipid profiles and carbohydrate metabolism, there is no evidence to suggest that the newer, less androgenic progestogens are any safer in terms of arterial thrombosis risk than older progestogens. Table number 2. Risk of venous thromboembolism, or VTE, associated with non-use combined hormonal contraception, or CHC use over the course of 1 year. Risk of venous thromboembolism per 10,000 healthy women over 1 year. Non-contraceptive users and not pregnant. 2. Combined hormonal contraception containing ethinyl estradiol plus levonorgestrel, norgestimate, or norethistérone, 5 to 7. Combined hormonal contraception containing ethanogestrel, ring, or norelgestromine, or patch, 6 to 12. Combined hormonal contraception containing ethinyl estradiol plus gestodine, desogestrel, or drospirenone, 9 to 12. Cyprotherone containing combined oral contraceptives. Cosiprendiol is a product containing the anti-androgen cyprotherone acetate of 2 mg in combination with ethinyl estradiol of 35 micrograms. It is licensed for the treatment of acne that has not responded to antibiotics, and while it can be used as a contraceptive, it should not be used solely for this purpose. The incidence of venous thromboembolism is 1.5 to 2 times higher in users of cosiprendiol than in users of levonorgestrel containing combined oral contraceptives, and that there may be similar risk to that associated with desogestrel, gestodine, and drospirenone containing combined oral contraceptives. The Medicines and Healthcare Regulatory Authority, or MHRA, issued updated advice for health professionals in the UK. The benefits of cosiprendiol outweigh the risk in women of reproductive age for the treatment of skin conditions related to androgen sensitivity, for example, severe acne with or without seborrhea, and hirsutism. Cosiprendiol provides effective contraception in these women. An additional hormonal contraceptive should not be used in combination with cosiprendiol. The need to continue treatment should be evaluated periodically by the treating physician. The risk of venous thromboembolism is rare, but this remains an important side effect, and healthcare professionals should themselves be vigilant for signs and counsel patients to remain vigilant for signs and symptoms. Duration of use. The risk of venous thromboembolism is highest in the 4 months following initiation of combined hormonal contraceptives or when restarting after a break of at least 1 month. The risk then reduces over the next year and remains stable thereafter. Although the risk is high in the first few months of CHC use and then falls, it remains higher than in non-users. Health professionals should be aware that compared to non-users, the risk of venous thromboembolism with use of combined hormonal contraceptives is approximately doubled, but that the absolute risk remains very low. Health professionals prescribing combined hormonal contraceptives should be guided by a woman's own personal preference, risk of venous thromboembolism, any contraindications, possible non-contraceptive benefits, and experience with other contraceptive formulations. A personal history of venous thromboembolism or having a known thrombogenic mutation represents an unacceptable health risk to combine hormonal contraceptive use. For women with a family history of venous thromboembolism, a negative thrombophilia screen does not necessarily exclude all thrombogenic mutations. A thrombophilia screen is not recommended routinely before prescribing combined hormonal contraceptives. Do progestogen-only methods of contraception like pill, injectable, implant, and intrauterine system increase the risk of venous thromboembolism? Data from a World Health Organization study suggested that there was little or no increased risk of VTE associated with use of oral or injectable progestogen-only methods. The progestogen-only injectable Norestray contains norethicirone enanthate or NETEN. No statistically significant increased risk has been observed for the levonorgestrel intrauterine system or the progestogen-only implant. There is no evidence to suggest that use of progestogen-only emergency contraception is associated with an increased risk of VTE. Progestogen-only methods of contraception do not appear to be associated with an increased risk of venous thromboembolism. What conditions increase the risk of VTE in women considering hormonal contraception? There is synergism between acquired risk factors associated with venous thrombosis, such as CHC use, antiphospholipid syndrome, pregnancy, surgery, trauma, immobilization, malignancy and high altitude, and genetic factors such as factor V Leiden mutation, prothrombin 20210A, protein C or protein S deficiency, and antithrombin 3 deficiency. The use of hormonal contraceptives, in particular CHC, in women with such conditions may negatively affect the balance of risk and therefore contraindicate the use of such methods. The UK Medical Eligibility Criteria for Contraceptive Use, or UKMEC, provides consensus-based recommendations to allow health professionals and individuals to select the most appropriate method of contraception without imposing unnecessary restrictions. On the balance of the available evidence and consensus opinion of experts, conditions are assigned one or four categories for each category of contraceptive methods. Table number 3. Definitions of UK Medical Eligibility Criteria categories for contraceptive use. UK MEC Category Number 1. Definition: a condition for which there is no restriction for the use of the contraceptive method. Category number 2. A condition for which the advantages of using the method generally outweigh the theoretical or proven risk. Category number 3. A condition where the theoretical or proven risk usually outweigh the advantages of using the method. The provision of a method requires expert clinical judgment and/or referral to a specialist contraceptive provider, since use of the method is not usually recommended unless other more appropriate methods are not available or not acceptable. Category number 4. A condition which represents an unacceptable health risk if the method is used. A clinical history should identify any conditions which fall within the categories 3 and 4 for use of hormonal contraception. Since progestogen-only methods do not increase the risk of VTE, most of the risk assessment relates to CHC use. Summary of UK MEC categories relevant to venous thromboembolism risk. The advantages of using the progestogen-only implant, injectable, and intrauterine methods generally outweigh the theoretical or proven risks in women who are anticoagulated. The CEU would advise ensuring that coagulation has been monitored recently. Faculty of Sexual and Reproductive Healthcare Guidance advises that there is generally no need to alter anticoagulant therapy if the woman is anticoagulated within the target therapeutic range. A community setting for fitting implants and intrauterine contraceptives is generally appropriate, providing there are no other risks, for example, severe vasovagal reaction. However, it is recommended that an experienced clinician performs the procedure with careful attention to hemostasis and application of a pressure bandage following implant procedures. Subcutaneous administration of the progestogen-only injectable, such as Cyanopress, can be considered as an alternative to IM injection. Faculty of Sexual and Reproductive Healthcare Guidance does not recommend the need for routine thrombophilia screening prior to use of CHC, as a negative screen may not exclude all types of thrombophilia. The United Kingdom Medical Eligibility Criteria for Contraceptive Use provides consensus-based recommendations for the use of contraception. A clinical history should be taken to identify any relevant medical conditions which may influence a contraceptive choice. A thrombophilia screen is not recommended routinely before use of combined hormonal contraceptive. Summary. Although the relative risk of venous thromboembolism does increase with combined hormonal contraceptive use, the absolute risk in women of reproductive age is very low. Other hormonal contraceptives do not appear to be associated with an increased risk of VTE, although more evidence is required, particularly for high-risk groups. Clinicians advising women on hormonal contraceptive use should be able to convey the risk of VTE and provide information on overall risk and benefits to help women judge the level of risk that is acceptable to them.